My name is Steve Grupp, and have the privilege today of chairing this session on CAR T cells. I'm joined by Helen Heslop from Baylor, and hopefully today we'll have a chance to explore both the CD19 and non-CD19 space in CAR T cells and put it at least in a little bit of context for bone marrow transplant. It's also supported, this symposium has been supported by grants from Kite and Novartis, and been organized by Carden Jennings Publishing. So with that, we'll see about getting started. So what I'll do today in the next half hour is spend a little time on data on CD19 CARs in leukemia. And then we'll hear about the non-CD19 space. When Carden Jennings organized this, they asked me to spend the first few minutes in introduction, so I'll do that, talking about the CAR T-cell technology in general. I think that most of the folks in the audience are probably more adult-focused than pediatric-focused, but there are a lot of pediatricians, and I think that all of us have a great deal of pride on the pediatric side about the advances that have been made in treating pediatric patients with ALL. However, I think the story is really completely different for the kind of patients that folks like us see in our practice, patients for whom they've experienced a relapse. And this is data from 2013, and it just looks at outcome after second or greater relapse of ALL. And the bottom line is that those patients do extremely poorly. So the modern intensified dose adjusted and risk adjusted chemotherapy that is given to ALL patients that puts 85 to 90% of those patients into long-term remission really doesn't work for this group of patients. And so regardless of what you do for these patients, and this is largely pre-immunotherapy, but absolutely including transplant, the outcomes are terrible. And then the other key point is that these patients get harder and harder to push into remission. After a first remission, after a first relapse, remission rates are usually pretty good, but in second and subsequent relapses, about a third of patients obtain another remission. And especially in pediatrics, we require an MRD negative or less than 0.1% MRD remission in order to proceed with transplant. We don't treat patients with transplant who have refractory disease. So this is a significant problem. I do have to update this slide because it says that leukemia is still the #1 cause of pediatric cancer mortality. That actually was not true as of this past year, where brain tumors are the #1 cause. But there's no question that this is a group of patients where we need better therapies. And so there are a variety of approaches to immunotherapy, but in the hematologic malignancy space, one of the most powerful by far is the concept of the chimeric antigen receptor, or CAR. And I'm sure you guys are familiar with the concept, but I'll go through this very briefly. Essentially, we're trying to take T cells and force them to recognize cancer cells in a way that actually destroys them. And if my movie works later, I'll show you what that looks like. And the problem is that T cells really have no recognition capacity for these self cells, and so we have to get around that by using a chimeric antigen receptor, which is this artificial molecule that's introduced into the T cell genome and then expressed on the surface of a T cell. And basically the idea is relatively straightforward, although the engineering is quite complicated. The external portion of the molecule drives an interaction with the tumor cell. In this case, we go after CD19, and there are lots of reasons why CD19 is chosen as a first target. It's safe. Really the only normal cell that you have in your body that expresses CD19 is B cells. You can live without your B cells. And it's very ubiquitously expressed across most B cell malignancies out to the sort of plasma cell myeloma stage. So these are all make CD19 a very favorable target. The interaction is actually driven by a piece of an antibody, a single chain FV. This is nice because if you have a target and you have a monoclonal antibody, you can make a CAR, and that's actually fairly straightforward. Inside, This is really the key why this works. There are pieces of the T cell activation machinery that are harnessed to activate these cells. There's CD3 zeta, which actually provides the first signal for cell activation, T cell activation, and then a co-stimulatory domain, or in newer CARs, sometimes more, that actually provide the licensing or co-stimulatory signal that actually allow for full activation of the T cells. And adding this in has really been an important step in getting these cells to work. And so you have a choice of CD28, or in our case, 41BB, which is the signaling domain that we've used in the CARs that we've studied. The general technique here, this is where the complexity comes in. This is logistically quite complex, but it's completely doable. So this is a personalized and precision medicine product that has to be made for every single patient. And that does get complicated. You have to apheresis these patients to collect cells, which include T cells in some percentage, anywhere from 10 to 80%. And once you have this mixture of peripheral blood mononuclear cells, they're cryopreserved, sent to the appropriate place, a GMP cell manufacturing facility, and then thawed for actual manufacturing, a process that takes, in general, about 10 to 12 days. There are variations on that, and then a period of time of about a week for release testing after that. And so what you're doing is you're taking these cells, which include T cells, you're exposing them to a virus. So all of the active CAR products in more advanced testing right now use this approach of a virus, either a retrovirus or a lentivirus, which is a crippled and modified form of HIV. And that modifies the T cell genome to permanently contain the CAR gene, and that results in the expression of the CAR protein on the surface. Now, it's interesting to note that the T cells still have their endogenous TCRs, but we're not sure what they do, if anything. This is a very polyclonal mix of T cells that are, and many T cells are transduced under these circumstances, but it doesn't appear that the endogenous TCR does anything. And for those of us who are interested in transplant, this suggests that there isn't necessarily a strong possibility for allogenicity in these products, even if you obtain a product from a patient who's had a transplant and who still has donor-derived T cells. And that's clinically what we see. This drives an interaction with the cancer cell, and we're hoping that several things happen at that point. Obviously, first, we hope that the cancer cell dies, and then we hope that the T cell becomes activated, and then most importantly, and this is a key point, the T cell has to proliferate. So proliferation is really key to these patients getting an initial clinical response. And then an interesting point, which I think we're still trying to sort out in the field, is the issue of persistence. T cells have the potential for long-term memory, and that may be valuable in a lot of ways in terms of preventing relapse, or that may be not so great in terms of toxicity, specifically B-cell aplasia. So how long do you actually need these T cells to be around to get longer-term clinical effects? And again, one of those key questions is whether this modality is a bridge to transplant or a potential substitute for transplant. And this is an area where everybody is still looking at these issues. I don't think it's a settled question at all. How you make these cells matter. This is sort of a technical point, but really the era of highly active cell therapy came when it became clear that activating T cells with some methodology that both, again, activate CD3 and CD28 produces cells that are highly proliferative, that have the ability to maintain these early T cell states that seem to correlate with both excellence in manufacturing, high proliferation, and the potential perhaps for persistence later. And so these manufacturing approaches, which are very similar, at least in concept across a lot of the different CAR platforms, are key to having adequate proliferation. Now, this is what this looks like. So this is, these green cells are ALL cells. It's actually drug-resistant ALL cells obtained from a patient and maintained as primary xenografts, now in a video micrograph. And here is a T cell that's been modified with a CAR, just actually a volunteer from the lab. And so what you see is the T cell comes, it docks, and then watch what happens to the cell membrane here. The cell membrane bubbles, and that's the formation of the membrane attack complex, complex and the destruction of the ALL cell. And the fact that this ALL cell could be hypodiploid, the fact that this ALL cell could have other unfavorable genetic characteristics, and the fact that it's drug resistant is irrelevant to what the T cell does. This particular method of killing is orthogonal to all of those issues. And I don't want to see it again. I just want the next slide. There we go. And the issue of proliferation, I think, is key. You can draw a line somewhere around 2010, before and after which you saw highly proliferative T cells that produced significant clinical responses in a large number of patients or not. And so this is the kind of thing that you see. These flow plots are all CD3 cells, and in the red box are the CAR-positive cells. This is very typical for our patients. This isn't a best-case scenario. And what you're seeing is that a day after the cells go in, this particular product, CTLA-19, directed against CD19. The day after the cells go in, you don't see any cells in the blood. This is all peripheral blood, but you see this in bone marrow and, as I'll show you, CSF. And then 2 weeks later, what's happened is that these cells have gone to sites of disease and in the tissues and have proliferated to an enormous extent and are now spilling out into the blood. And so most of the cells, most of the T cells in these patients are CAR modified. So in this particular patient, 71% of the T cells are CAR modified. Now, this is antigen-driven cell proliferation, although homeostatic expansion in a lymphodepleted patient is probably an important part of the mechanism. This is absolutely antigen-driven because the CAR-positive cells infused into the patients are the ones that actually proliferate. This is getting broader and broader, but still, if you look at the programs that have the most mature clinical data, we see several approaches. So the approach pioneered by Penn and now being developed by Novartis is the approach that I'll be talking about today. And here, the co-stimulatory domain is 4-1BB. This is a lentiviral approach. The group at the NCI has partnered with a company, Kite, has a CD28 CAR and a retroviral transduction approach, and the group at Sloan partnered with the company Juno, also having a CD28 and a retroviral approach. And there are variations on this coming along, but these are the three that have the clearest published data at this point in time. And across these platforms, the initial efficacy is very similar. So the CR rates, I mean, it all depends on how you define your study and where you start counting, and but the CR rates are in the 80 to 90% range, and I would say that they're very similar across all different CARs. I think the big difference is persistence, where I don't know that it's CD28 as the causative agent, but as a shortcut to say the CD28 CARs are CARs that persist for a month or two, and the 4-1BB CARs are persisting in patients out to 5 and 6 years now, maintaining B-cell aplasia and long-term remissions. We presented data on this, and I'm going to go through this very quickly, but this is from ASH in 2015. We're due for an update of these data soon, and this is a single institution phase 1/2A trial where 93% of patients with relapsed refractory ALL, including patients, a large number of patients who had relapsed after transplant, went into remission at 28 days. Of these patients, 59 of them, only 6 went on to subsequent transplant, and remember that a lot of them had already had a transplant. And the overall survival in this group of patients at a year is 79%. So we're not seeing a lot of relapses past a year, but we only have about a dozen kids, 18 kids at this point, who are past a year, so we still have to monitor these patients in terms of their overall survival. But the 12-month relapse-free survival, which I think is a very relevant number, is 55%. This is the overall survival curve. This says no relapses past a year, but we have had one patient that's experienced that since we published these data, or rather presented these data at ASH. I think a key point in thinking about this as an immunotherapy is that it works about as well regardless of your disease burden. So patients who have MRD, we can get in an MRD remission. Patients who have 5% blasts, we can get into a remission. Patients who have 50% blasts, we can get into a remission 83% of the time. And this suggests that this is relatively insensitive to disease burden. Now, toxicity is not insensitive to disease burden, and I'll make that point. These cells go to the CSF. They're found in the spinal fluid. And there is a potential for these cells to control CNS disease, and I think for an ALL doc, that's a particularly interesting finding. In 98% of the patients have these cells in their CSF, and we have not seen any CNS relapses in these patients. One patient that I actually saw in clinic this past week had Philadelphia positive disease, relapsed, had a transplant, relapsed in the CNS, relapsed 5 more times, always got back into remission, always relapsed again. Got CTLA-19 3 years ago, remains in remission with no further therapy, no intrathecal therapy, and no further transplant 3 years later. Toxicity is important. So cytokine release syndrome, sort of a overlapping syndrome with cytokine storm, so familiar to all of us who take care of transplant patients. It's characterized in its initial phases by high fevers and myalgias, and these patients can have fevers in the 40-41 range, not uncommonly. But there is a severe form that absolutely happens in patients, and that can be associated with unstable hypotension and can proceed to the need for mechanical ventilation. So that is a significant issue for these patients. Interestingly, there was a great session yesterday talking about inflammation in patients and talking about HLH and macrophage activation syndrome. This CRS is really partially a macrophage activation syndrome, and it's characterized by incredibly high ferritins. And so Dave Tichy in our group suggested early on that these patients looked like, these CRS patients look like MAS patients. We should check a ferritin. And so this graph shows you patients who don't have severe CRS or do, and basically, these are patients going to the ICU, and these are patients who aren't. And what you see is that all patients have very high ferritins, 5,000 or above, but that patients with bad CRS have 100-fold higher ferritins. And some of these patients have hundreds of thousands ferritin levels. It's actually kind of hard to measure this, but clearly there's a significant MAS-type response in these patients. This is really driven, and I think this is a seminal observation that has allowed us to give these cells safely by interleukin-6. And I won't get into all the details associated with that in the time that I have available. But basically, these graphs are showing you patients in green, high disease burden, who went into CR, in blue, a patient who didn't have a response, and then in red, a patient with low disease burden who went into CR. So we see a little bump in IL-6. This is a 10-fold scale over here, and then a crazy bump in IL-6 in patients who have high disease burden and bad CRS. And so there are lots of cytokines that are elevated. Again, David Tichy has done amazing work in this regard, but IL-6 seems to be extremely important. And again, if you look at the analysis where it separates patients who do and don't go to the ICU, interferon gamma, as you would expect as an effector cytokine, is quite elevated in these patients and much higher in patients who have bad CRS. That, until very recently, was not druggable, and I'm not sure I would want to drug it because I might interfere with the therapeutic effect. We don't know that, of course. Sorry, interferon gamma is over here. This is interferon gamma, 100-fold higher in patients with bad CRS. But interleukin-6, same thing, 100-fold higher in patients with bad CRS. And that is druggable with this drug tocilizumab, which now has been used across the CAR platforms, blocking IL-6-mediated effects. It has various indications in the rheumatoid arthritis area. It's obviously not indicated for this purpose, and we use the package dose, and it's quite effective at controlling this. I think the key point in terms of thinking about these patients is that their risk of CRS is really dependent on their disease burden. So again, this yes-no analysis, did you go to the unit, did you not? And you see patients who have marrow disease over 50% have a very high likelihood of going to the intensive care unit. And if you look at the 3 patients who didn't, who had high disease burden, 2 of them didn't have a response. That's what the open circles are. So clearly, the cells will grow to get on top of a high disease burden, but it is absolutely associated with significant toxicity in those patients. The flip side is, if you can treat patients in the lower disease burden range, let's say less than 10% blasts, they're not going to the ICU, probably less than 2% of the time. I won't get into the predictive modeling. This is a little bit too specific. So basically, we've learned a lot about CRS for these patients, and we're seeing it in almost everybody. As a matter of fact, the parents have so internalized this notion that you need high fever to have a response that if the patients are doing well, they're terribly worried about that. But 12% of our patients stay outpatients, don't get a fever, and aren't admitted to the hospital. And I want to emphasize that we give these cells in the clinic. The administration of the cells is not the hard part. It's the few days afterwards if they develop CRS. So if you get a fever, you get admitted to the hospital because you're a leukemia patient with a central line who's also neutropenic at the same time from your lymphodepleting chemotherapy. The index lesion in CRS is unstable hypotension. So you get the fever first, this is fairly predictable, and then you get the hypotension within a day or so or longer depending on the patient and the disease burden. The higher disease burden, the faster this happens. But it is perfectly safe to have these patients afebrile and at home until they spike, bring them into the hospital, and then follow their course after that point. Right now we're intervening for patients who have unstable hypotension who are going to the ICU with tocilizumab, and of course the obvious question is whether it's appropriate to do that earlier. Reasons that this doesn't work: it doesn't work in patients 7% of the time, probably because the T cells don't grow well. If the T cells disappear by 4 to 6 months, I worry about the possibility of CD19 positive relapse because the T cells haven't been there long enough. But there's also absolutely a phenomenon of CD19 negative relapse, and the patients who relapse are more often CD19 negative than CD19 positive, and those patients have persistent CARs, but the CARs can't see the ALL because the external portion of CD19 that the CARs see is gone. So since that's a significant problem for our patients who achieve wonderful remissions, MRD negative in almost all cases, but unfortunately have the experience of CD19 escape and therefore a relapse for that reason, what do we do about this? And the proposal that's been made by a number of groups is to use a second antigen, and one of the antigens that's been proposed, which is on 90% of ALL but not 100%, is CD22. And the group of the NCI, Terry Fry, Nurali Shah, have done work on this. We have a CD22 CAR, and I think the proposal in the future may be to combine these two modalities, but that hasn't been done as any kind of published clinical trial that I'm aware of. So CRS we've already talked about. I do want to acknowledge, because it's in the news these days, neurotoxicity. The reason it's in the news is that the Juno program had a significant problem. After many patients treated, they didn't see this. We haven't seen it, and the Kite folks, as far as I know, haven't seen it, but saw cerebral edema in several patients, and this was a fatal and rapid outcome in some of these patients. Significant concern that has halted that trial for the time being. And so for us, what we see in terms of neurotoxicity, and we absolutely see neurotoxicity, is we see delirium associated with high fevers and medications. That is definitely associated with the CAR. Whether it's directly causative, I don't know. I mean, you got the fever from the CAR, so yes. But there's also a very characteristic encephalopathy in these patients who, after their CRS is over, are awake but not speaking or following commands for 2 or 3 days. It's very characteristic, and it goes away. There's onset overnight. It lasts for 2 or 3 days, very rarely longer. It resolves completely in all patients. We haven't treated these patients with anything. They aren't getting dexamethasone. We scan them, and their scans look normal. We have not seen any cerebral edema. And then we've seen seizures in a very small number of patients. And then the other toxicity that you have to be clear about is, of course, B-cell aplasia, because as long as the CAR cells are there and killing CD19 cells, they can't tell the difference between a good B cell and a bad B cell. So these patients are on IVIG replacement. And the first patient I treated almost 5 years ago, in about a month, that patient remains in remission, never had a transplant, has B-cell aplasia, and is still getting Hizentra, which is the subcutaneous form of IVIG. This has led now to a registration trial for this product, and this was sponsored and run by the drug company Novartis that has licensed this product. And this trial, Eliana, was performed at 25 centers across the world in 11 countries, a global supply chain of cells made at a manufacturing facility by Novartis. And this is an absolute first. And the question in our minds was whether we could see the same efficacy and safety in a multi-institutional trial, a question that I have gotten at least 100 times and entirely appropriately across multiple centers and multiple countries, and multiple continents. And this was a logistical tour de force that the Novartis people put together. It was an incredible effort, and the folks involved in the study have worked very hard to make this work. This is a snapshot of the data. This is being updated as we speak, but in this snapshot, 98% of the patients were 98 patients were screened, 81 patients enrolled, 62 patients infused. Some of these patients hadn't been infused yet by the time we did this snapshot. The primary analysis was the efficacy in the first 50 patients who were actually infused, because that's the comparison to the CHOP-UPenn data that I presented a few slides ago. But let's briefly explore why patients didn't get the cells. Some of the patients died before they could receive their cells. There were 6% manufacturing failures on this study, so there are patients for whom we can't make cells, and it's less than 10%. And patients who lost their eligibility for other adverse events are reasons why they didn't get the cells. So looking at the primary efficacy analysis, these are first 50 patients infused, which was the initial analysis that we agreed with the FDA, and 82% of those patients went into a complete response, all of which were MRD negative, some of which were complete response with incomplete count recovery, so 68 patients CR and 14 patients CRI. So all MRD negative, but some patients who take definitely more than a month to get their counts back, and more than you would expect just from the chemotherapy. So the conclusions from that pivotal trial at this point in time is that we saw very high efficacy in this group of relapsed refractory patients. They had to have more than 5% blasts in enrollment. This is very comparable to the CHOP-UPenn data that I showed you previously. So that first question of can you do it with similar efficacy in multiple centers, I think the answer is yes, and I greatly appreciate the hard work of all of those centers. All of these CRs were MRD negative. This is by the U.S. approach of using multi-parameter flow cytometry. We were not doing allele-specific PCR regularly in these patients, and we were not doing next-gen sequencing, although samples exist, I imagine, to do those tests. Don't know what we would see with next-gen since it's slightly more sensitive. A lot of patients with durable complete remissions were observed, very similar 6 and now 12-month OS and EFS as we saw in the UPenn CHOP data. So that also I think is very promising. A number of patients who did not require transplant afterwards, some of which had already had a transplant, second transplant. You can absolutely do them. I certainly have, but it's a question whether that's necessary or standard of care. And then patients with refractory disease who this was their first opportunity for transplant, but who still have waited if they have good CAR persistence about getting transplantation. The CRS was manageable, so safety was exactly the same across this multi-institutional trial with no deaths due to CRS in these patients, although absolutely patients go to the ICU. In our broader experience, about a third of these patients go to the ICU. On this particular trial, 44% of the patients go to the ICU. There was an understandable degree of caution about CRS in these patients, but it's really been remarkable to me. Transplanters know how to take care of patients who have these sorts of complications. Yes, CRS in CAR T cells is a little bit different, but you can apply some of the same thought constructs, and we have an excellent toxicity management strategy that has really been very helpful in the vast majority of these patients. So I would say we haven't seen any new safety findings. We haven't seen any new findings associated with CRS. We see the same rate of grade 3 and 4 CRS, and we haven't seen deaths either from neurotoxicity or from CRS. So the highest grade neurotoxicity on this trial was grade 3. So it looks like this particular cell product does have, it might potentially be a treatment option for patients with refractory and relapsed ALL. It may present the possibility of post-transplant salvage. I think there's no question about that in my mind with a 93%, 82 to 93% CR rate. So I think that that's definitely there. And then the question in our minds as cell therapists, you can deliver a cell therapy with transplant, you can deliver a cell therapy with CAR T cells. Is there an opportunity to do this as definitive therapy and not necessarily take all of these patients to transplant? And that's certainly something that our center and these groups have explored. Again, I don't think this is in any way settled, but it's a great thing to be thinking about, and it's certainly what families are looking for if there's an opportunity to do this without the risk of graft versus host disease, which we've seen in none of these patients. I think there's real value for that. So I think we can do a lot here. We can get patients back into remission. We can get rid of their MRD. We can do this in a multi-center center. We can do this in a global setting. We can do the supply, the logistics of collecting these cells, manufacturing them, sending them all over the world, Australia, Canada, Japan, EU. It's incredible, but it is doable. Not easy, but it's doable. We can think about stem cell transplant. This is actually the young lady who, if you hear my phone going off, it's her dad texting me. I don't actually know why, but this young lady is now almost 5 years out, remains in remission, who came to us for transplant. We couldn't get her into remission. We got her into remission with CAR T cells. The family said, we're more interested in school than transplant, and she remains transplant and disease-free. And this has now led to a discussion of how this might look if you do this in patients who are very high risk at diagnosis or because of persistent MRD after 2 cycles of chemotherapy. And Steve Hunger, the former COG ALL cell chair, and Mignon Lowe, the current COG ALL chair, as well as John Levine, who runs stem cell transplant for ALL, we're all working together to try to develop a study for earlier use. And in this group of patients, these patients are going to have MRD level disease, and almost none of them will go to the ICU. And this is, again, the young lady that we treated first off in 2012 because she went to the White House, because she met the president, because I'm not exactly sure why, but that's actually with the president. I will say, and you've probably heard this before, and I apologize, but I love this story. She got to meet Obama separately, and the president asked her, the former president, oh God, asked her, you seem like a really cool kid. What can I do for you? And she said, well, I'm missing school for this, so could you write me a note for my teacher? So good for her. I'm going to end now with 4 seconds to go. We will take questions at the end, but I just want to acknowledge the many people involved in this study. Carl June, who runs the cell therapy group at the University of Pennsylvania, the fabulous people that I work with in my lab, Dave Barrett, Dave Tichy, Shannon Maud, who has done such amazing work on the clinical trials and been such a fantastic colleague for me at CHOP, and who will be running this COG early treatment trial. Bruce Levine, who makes these cells, the folks at Novartis who got the logistics to work on a global scale, and many other people, of course, obviously, including the families who actually participate in the trials. And with that, I'm going to stop. I'm going to turn it over to Dr. Heslop, who will talk to us next, and then both of us will be available for questions at the end. Thank you very much.